very good afternoon to all. Thank you for your very kind introduction. I am Nazimi. I'm going to talk to you this afternoon about the 3D printing technology. I'm going to go beyond the 3D printing to introduce you to the computerized technique in maxillofacial surgery, as well as the use of navigation surgery. And I'm sure many of you have heard about the 3D printing technology. It has been there for years for many industries, such as the engineering, the automotive, as well, even as a hobby. And for the medical, I think we rarely heard about 3D printing. And for the discussion today, I would like to introduce the use of all three technology in our surgery. Before I move on, I just want to know, how many of you have heard about oral and maxillofacial surgery? Please put up your hand. Not that many. I'm a bit alone here today. But this specialty is basically very close to my heart because anything that we do in terms of diagnosis and the treatment for the patient, we cannot hide. It's going to appear to the public that they have a deformity and so on when they have a functional deficit as well. And this is a common scenario that we see here in Kuala Lumpur, in which that we have a traffic of others, and when they go to the hospital, they will have a scan, something like this. And I'm very careful in terms of interpretation of the CT scan because whenever we have cases like this, we have to make the majority of it with a big decision. But it's unfair to rely on the small images. The second thing was that all these images contain 3D information. And why we're using 2 dimensions to analyze and go for the surgery. And this is what we get if we really process the data, use the data, and translate the data into the surgery. And there's no rocket science here. Basically, the data is a non-proprietary data. You can use it in many platforms as long as you know on how to extract the data from the scan. And for the purpose of today, I just want to cover some aspect of the maxillofacial trauma and also maxillofacial tumor, and I will not touch into the orthodontic surgery, which will be more complicated. This patient was referred to me after several weeks of polytrauma. She nearly lost her life. And this was a scan taken for the diagnostic imaging. And I want to turn this into a functional imaging in which we're going to use the data to go for the surgery. You can see a severe deformity in the mid-facial region, and she presented and asked me whether I can correct her face. And this was my initial plan. I intended to do the cut onto the bone, the depressed bone, and replace it with the titanium. But I feel a bit skeptical, number one, because I have to go very close to the brain, the area that I don't have any, what we call this training to deal with. And number two, I'm going to involve the right orbit. She actually basically discussed it with the family, and I don't think that this is something that we're going to do because the only seeing eye is the right eye. I don't want to make any of my patients to go blind after surgery. So we revised the plan, and this is the extreme end of the 3D printing in the medical and surgical industry in which we can print the implantable material. So it is a customized treatment for patients, and this is how it looked like when it was delivered to me. I kind of like the scaffolding underneath because of the strength that is actually very close to the surrounding strong bone. And this was during the surgery. It snugly fit into the surgical area, and we finished this in slightly less than 2 hours. And she was home after about 5 days of hospitalization. And this was the analysis that you can do following the surgery, where we can get the preoperative data and post-operative data together, and we do the chromatography analysis. And we were happy to say to our patient that you have a 98% of the implant that were within the 2 millimeter range of accuracy. And this was her before and after the operation. And for a female patient, it's very easy to know when they are happy with the surgery. They will come to you with the makeup on. So we can really tell that. We can also use the 3D printing to print the physical model where you can do the mock surgery prior to the actual surgery. So this case illustrated the fracture mandible, a comminuted fracture mandible, where there is the presence of anterior open bite that we can correct by having the mock surgery beforehand, before we go even to the surgery itself. And nowadays, I do a lot more of a virtual modeling in which I don't print the physical model, but I do everything on the screen, and I use the information from the unaffected, uninjured contralateral side to do the reconstruction. And you have an option to print the model, and you can do the pre-bending of your titanium implant prior to go for your surgery. And this can be translated directly into the surgery. You can see that the model cannot be sterilized. That was, I think, a couple of years ago. Now, we can have the model that can go to autoclave and can be used directly in the surgery. So that's the right orbital floor fracture reconstruction. And a short video to show that this is the abnormal looking mandible. I'm sure many of you will agree with me that we can do the simulation of the surgery, the computerized technique, to exactly delineate the area that we want to remove, and to make sure that we get it right, as we cannot afford for our patient to have the asymmetry as well as the injury to the nearby vital structures such as the nerve as well as the teeth. So you can do this now even before you go to the surgery, and the product will be the 3D custom guide. So here we go on the left and on the right. So that's the mandible after we do the surgery, and we can do the segmentation of each of the particular area that you are intended to save or to remove. So you have seen the 3D printed implant. You have seen the 3D printed patient-specific cutting guides and the medical model. I would like to introduce you to my little robot here, where you can use the intraoperative navigation to further enhance your operative decision. This is another case of the tumor on the right mandible. This is a benign tumor, but somehow we need to resect the mandible, and we need to make sure that the functions of the mandible will not be disturbed after the surgery. And it's a very demanding outcome for the mandibular reconstruction. We have to make sure we maintain the good articulation. We have to make sure we maintain the bone continuity for the purpose of future rehabilitation with the dental implants, for example, or with the use of dentures. But most of the time, what we see from the conventional technique is the exposure and also the fracture of our material. And also, we lost the continuity as well as the shape of the mandible. And most of it is not going to have a good function afterwards. So without a plan, we are planning to fail. Obviously, we have seen a lot of failure with the conventional methods. So with the use of 3D print as well as the computerized technique, we can now do the tumor mapping. We can remove the tumor virtually, and we can straight away do the reconstructions by using the patient's own bone, taking from patient's leg. And this is what we see on the screen. And one thing I like about this technique was that it's easy for me to communicate with my patient, for them to make a decision prior to go to this major surgery. And this is what we see, and this is what we print toward the ends of the planning with a 3D printed fibula. But this is not the one that we're going to put in the patient. This is not an implantable material. This is just a guide for us to use in the surgery. So in the surgery, we have the template side by side with the bone that is from the leg. And with the use of this little robot here, we can determine, especially the angle of the jaw, where this is the area that is very important for us to maintain the continuity of the jaw as well as to maintain the symmetrical of the jaw. And of it, we have this at the end of surgery, normally at about 8 to probably 6 hours after the surgery. And at that time, as a human being, you are going to be affected by your physiological barrier. You get tired, you get fatigued, and sometimes you get angry. And this is what we have. The computer will tell us where to place the bone in the surgery. And this is another view to show we can have views in all directions. And it is a dynamic process where you can always adjust to the positions that according to your plan. And similarly, the implant-oriented navigation surgery you can use for the orbital reconstruction. We don't do any physical modeling here. We just base onto the virtual modeling where you can import the implant data. You get this from the industry. You have to work with the industry, and you simulate the surgery even a couple of days before it will be okay for you to get a good result. And here we can go really posterior or at the back of the orbit, and not to compromise any other vital structure around that particular important area. And similarly, you can have surgical outcome validation. This is very important for us to validate our surgery, to show to our patient that, look, we have achieved what we need to achieve. What we plan, we'll be able to translate. Then that's always a challenge for us to always attain a good result. We have a lot of tasks at hand. We have a lot of challenging cases here, even in Malaysia. We see many, many cases coming to us with all sort of a disease as well as a defect as a result from the first surgery. And we need to have a vision. We need to work as a team. We need to work it out by going out from our comfortable zone and develop this together with this industry. And out of silo, I think we can achieve a lot more in terms of the outcome, because the first surgery is always the first surgery for our patient. With that, I thank you very much for your kind attention.